we heard a lot today about individualizing care. We hear a lot about precision medicine. And what I'm going to talk about for the next 15 minutes is an approach to the critical care of the most severe forms of stroke that focuses on exactly that approach. And that approach is called brain multimodality monitoring. This is going inside the black box of the comatose human brain. I mean, we think of using ICUs as a place where we monitor closely and we can react when bad stuff's happening. And then maybe we can stop the bad stuff, but the bad stuff's already in progress. So the idea of multimodality monitoring is to create an optimized physiologic environment for the comatose human brain and try to prevent these brain swelling events, prevent these seizures, prevent these herniation events from occurring in the first place. This movie came out when I was 15 years old. It was a sci-fi thriller, and it featured human beings in states of suspended animation. And this is where I work now. This is the modern critical care unit of today. And it's actually way cooler than the movie ever was or could have imagined. And I'm going to just spend some time here talking about the different technologies that we have access to that we can use to monitor the brain, some really amazing stuff, and talk about an approach, my personal approach, an approach that I'm looking forward to continuing to bring with my partners at Henry Ford to this part of the United States. If you like toys and gizmos, gadgets and gizmos and gadgets and stuff like that, then you love being a neurointensivist because we have more than any other field of critical care medicine. And it's these monitors that can measure cerebral blood flow directly, right, using thermodilution curve techniques. That used to be a dream. We have it. We can measure the partial pressure of oxygen in the brain. Oxygen is what the brain needs and needs more than any other tissue to survive. We can monitor brain metabolism and neurochemistry. We can measure glucose levels in the brain. The neurons survive on two things, oxygen and glucose. And we can do microdialysis now to do real-time neurochemical monitoring, which will take us inside the black box and be able to look at the physiology of what's driving damage and informing us about what we can do to arrest damage and prevent damage. And the analogy that I would use is flying an airplane. If your patient is awake and has a baseline level of high brain function, high cognitive function, everything moves, they can count backwards, you don't need to drill holes and put monitors in their brain. You can follow the neurologic exam. They're also low risk, right? They're doing relatively well. This would be like flying an airplane in the daytime. But what about when your patient's in the darkness in the shroud of coma? There is no high-level brain function to follow. And on top of that, comatose patients tend to be intubated and monitored. And what we see over and over again, right, and this is the real world in other people's units, one day you say, gee, we turn the sedation off, the guy's not waking up or not doing as well as he was, and you get a scan and you see all these new strokes that weren't there before, or brain swelling that wasn't there before. Maybe there were buildups of intracranial pressure you didn't know. So I think that to give our patients the best chance when they're in a coma, in addition to intracranial pressure monitoring, we should use these tools to give us better situational awareness. So we understand what's really going on, and we can use this technology to build improved techniques, improve management strategies. So it's like flying a plane with your instruments, with your gauges, that can tell you about your velocity and your altitude and changes in air pressure and everything else, as opposed to flying in the dark, where your worry is that you're just going to crash right into the mountain. So we have a lot of these different types of modality, EEG and brain oxygen, ICP, PRX, which is a derivative of ICP, as I said. And one of the problems is we develop these new channels of data. It can be very hard to try to pick it apart and understand it. And what you see here is the common paradigm of simply time series data, right? And you're watching all the squiggles going up and down, and you're trying to figure out, is this related to that? And it's hard. It's hard to pick apart. So one thing we know is if you're doing multimodality monitoring, we need a data acquisition system that can grab all these different lines of data and connect them so that you've got them all together, and then you can start to look at relationships of one different measure to another. So one of the big flaws, what I find when people say, a lot of people are like, I don't believe in ICP, I don't believe it helps anybody, or I don't believe in brain tissue oxygen monitoring. One of the big drawbacks is what I call, it's the blind end box. So you just got this monitor displaying a number, and you can walk by and look at the number, right? And then the number's gone. And in one scenario, you write down what the number was, a 12 or 1 or 2 or 3. There's so much richness in that data, we're just basically flushing it and wasting it. So in ICUs, what we need to do is to collect that data and store that data permanently. And then that allows us to go look back over the last 6 hours or the last 24 hours and start to look for relationships and get insights. So as we develop more and more of these types of monitors, it's the data acquisition system and the data visualization, so-called big data in the ICU, that's going to help us make inroads. The types of devices that can do that you see here on the right is what we had set up when I was at Columbia, in the Columbia Neuro ICU. We got dedicated computers in each ICU room, dedicated continuous EEG, and we put everything on one kind of mainframe server in a database called SQL. It was good, it worked. Only drawback was we needed a full-time PhD to build and manage the system, which who has that, right? On the left, you see something called the Moberg CNS monitor. This is commercially available. It costs about $50,000. And this is designed to, you can plug and play, connect all your different monitors, it'll store it, and it can display data for you in retrospect. You can combine data sets. And also, interestingly, these things can do ECOG, or electrocorticography, which is another cutting-edge technology that we'll probably be talking more about next year. But what you want is your integrated data information system. And then I put all these different types of boxes and machines in two groups, right? On the right are the physiologic drivers. This is what we control. I can raise your blood pressure, lower it, right? I can boost your cardiac output. I can cool you. We can make you hyperosmolar, right? Hypernatremic. We can calm and sedate your brain. We can hyperventilate you or do intentional hypoventilation. And what you see on the left are the measures of physiologic brain health. What do we want? We want healthy, high amplitude EEGs that react to stimuli. We want normal flow, normal oxygenation, enough glucose, but not too much glucose in the brain. We don't want seizures, right? We don't want ischemia, which you can measure with microdialysis. So the idea is to turn the dials on the right to optimize the physiology so that the needles on the left move out of the red zone and into the green zone and into the healthy zone. And this is the process by which we can create the optimized physiologic environment for the comatose human brain. So we're not reacting to ICP crisis. We're preventing ICP crisis from happening. And we're not reacting to an evolving stroke in a patient with vasospasm. We're preventing the stroke from happening in the first place. And one of the ways that we begin to use these systems is to look at real-time physiologic relationship. So I'm going to introduce you to the Lycox. This is a brain tissue oxygen monitor. It is a small, thin little probe, just about 1.5 millimeters in diameter. It slides about 4 or 5 centimeters into the brain. And it's just like an ABG for the brain. It measures oxygen tension in the brain, which normally is about 40. As the oxygen is getting offloaded off the hemoglobin and just soaring through the neuropil out of capillaries and getting sucked up by the neurons, which are little, oxygen engines, and oxygen is their fuel. This is a slide, part of the motivation of this approach. Why does every poor grade subarachnoid hemorrhage benefit from having this kind of monitoring? Because they can develop infarcts that are asymptomatic. And these are just some examples of patients that I treated where they ended up with infarcts, but we didn't know they were happening, so we couldn't react. We didn't know that we had to raise the blood pressure, try to normalize the situation, optimize blood flow and oxygen delivery. We didn't know. We didn't know they needed to go to angio. They just lied there comatose. We know with brain oxygen monitoring from observational cohorts that the more brain tissue hypoxia there is, the worse you do, the more likely you are to die. Now, this doesn't prove that our efforts to try and normalize oxygenation will improve outcome. But by taking this approach, we have a testable hypothesis. And that's how you move a field. And in fact, that is the hypothesis of a study called BOOST, which is looking at ICP and brain oxygen targeted critical care as opposed to ICP alone. Turns out you can manipulate brain tissue oxygen levels. And in many patients, they actually fluctuate in parallel with cerebral perfusion pressure. You can calm down the brain and reduce oxygen consumption and normalize treat brain tissue hypoxia that way. So I showed this my most recent grand rounds, again, for those that were there. One of my very first Lycox patients, we put a Lycox monitor in the right frontal lobe. And in the first night, you have midnight dead center. That's about 11 p.m. This is 1 a.m. So this is in the middle of the night. And you see the brain oxygen is kind of dancing up and down from as high as 40 down to as low as 10. And you see the cerebral perfusion pressure. This is a pressure being taken off an arterial line. The curves are identical. The brain oxygen levels are completely fluctuating as a consequence of the blood pressure. And when you take that data and plot it, you see a straight line relationship. So now we know to manage this guy, we need a CPP up 70, 80, 90, not down 40, 50. This curve reminds you of this curve. So now we understand that in addition to an early warning system, if you have this data and you connect it, you can actually image cerebral autoregulatory curves in human beings in real time. Microdialysis looks like this. It's a flexible little catheter that goes in the brain. You get hourly measurements of the chemistry in the extracellular compartment. In addition to glucose, we can calculate the lactate pyruvate ratio. When tissue is ischemic, the LPR goes up. Glutamate is a toxic neurotransmitter. Glycerol is released as an endgame situation from damaged cell membranes when cells are actually dying. The earliest studies using microdialysis in trauma showed, as expected, the lactate pyruvate ratio goes up when cerebral perfusion pressure is at its lowest in trauma patients. And the first study looking at microdialysis in trauma patients with seizures showed that the lactate pyruvate ratio is higher in a set of patients when they're seizing compared to where they're not seizing, because metabolic demand goes up. So this was the neuromonitoring bundle that was developed at Columbia using a triple lumen and a dual lumen bolt. And these were some discoveries that were made in that era just to get us started. First of all, autoregulatory dysfunction is rampant after poor grade ICH, SAH, and trauma. And that Here's an example, a probe here around a penumbra, if you will, or perihematomal brain of an ICH. And in a group of about 40 patients, you see the dotted line is a substantial increase in the rate of brain tissue hypoxia. And you also see more metabolic crisis with lactate pyruvate elevation when blood pressures are lower. So we may think that a CPP of 60 or 70 is good in trauma, but this data suggests that an ICH, it ain't enough. This is one patient where what we can see here is we see autoregulatory failure in the upper left, and then we see it normalize dynamically over 1, 2, 3, and 4 days. We learned that tight glycemic control can be dangerous in comatose brains. We know that brain glucose levels go down in non-survivors, and what this shows here is an increase. What you see here is more brain hypoglycemia when you're targeting tight glycemic control and sometimes over-treating it. We also found that glucose has difficulty with active transport getting into the brain, as shown here. Lower ratios of brain to serum glucose associated with higher mortality, I know I deserve it, and, and more metabolic distress. We learned that fever is bad, and that fever, the treatment of fever early on is associated with more brain tissue hypoxia. That led us to develop the Columbia anti-shivering protocol, where we focused on more effective non-pharmacologic methods for reducing the metabolic burden of shivering. We were able to uncover problems with unintentional brain tissue hypoxia resulting from central hyperventilation. We've been able to look at relationships with anemia and brain tissue oxygen levels, and I'll just show you this. Comatose cardiac arrest patient, flat EEG. The bottom leads are a depth electrode in his brain. You see generalized discharges, and you see on top pseudo-normalization while the guy's having this incredible seizure deep in his brain, unbeknownst to us, even if we're doing surface EEG. It turns out that probably 30 to 40% of coma patients are seizing deep in their brain. So this is just the beginning of a new era, a new area to explore and continue to innovate and try to improve outcomes for the sickest of the sick with SAH, ICH, trauma, and status epilepticus. Thank you.